And next we're going to have Patricia Pagnotta come up.
So if you see me looking at my wrist, it's because I'm on a timer. So thank you all so much for coming out. It's great to see a large crowd like this to come out for a women's program. And Dr. Issa did a great job. It's a hard thing to step up here in front of a group of women. Anyhow, so I'm charged with tonight talking about things of wellness, nutrition, parenting, the impact on family, and then women and specific MS symptoms related to being a woman. So really, when I look at wellness, wellness is really a being of creating this concept that I call resilience. And it's having the right attitude, empowering yourself to be more than MS, redefining yourself, and having hope for a full life. Because irregardless of what we treat an individual with, as Dr. Issa talked about, trying to minimize medications, because you could come into our office and we could be giving you something for every little thing you complain about, that may not be beneficial to you. The key is you have to develop a desire, a willingness, a resilience to want to be all that you can be. And you'll find that will lead you a long way. So what exactly is this? It's defined as the capability of a strained body to recover its size, shape after deformation by compressive stress. And what can be more stressful than MS? So your ability to recover from or adjust easily from misfortune or change. So that's the process where a person goes through getting this chronic disease, adjusting to it, and learning to assimilate their life and move forward. Some people never develop that. And I can tell you, if I could put in a pill one thing that could have the biggest impact on MS, it would not be the disease-modifying drugs that we have. Although I don't want in any way for you to think that I'm discounting those medications, because we have 15 great drugs now. But if you don't have the heart, the desire to be healthy, to be more than MS, the medications are going to modify your disease, but I've seen people become very, very sick when their MS is doing very, very well from everything that we can measure. So resilience is a important concept, an important way about living your life, whether it's MS or anything else. But what specifically about MS can threaten your ability to be resilient? Well, we know that this is a neurodegenerative condition. This is a chronic medical condition that is characterized by relapses, where your symptoms come, they become much more apparent for a period of time, cause disability for a period of time, and maybe that will resolve itself and you'll get better. But over time, the other hallmark is that persons will become disabled. Now that time frame for some people is decades. For some people, it's just maybe a matter of a few years. We don't, unfortunately, have a crystal ball where we can put a thermometer in someone's mouth or look through this magical MRI that's so beautiful and say, okay, well, this is where you're going to be in 3 years. This is what we need to do for you. We don't have that ability. Often, neuropsychological complications that arise from this disease related to the inflammation and demyelination make it difficult for persons to be able to be resilient. The anxiety, the depression, things that we know come along with MS. And again, the fact that this is a chronic degenerative disease threatens a person's personal autonomy, independence and dignity, and future plans. And that can be very paralyzing in itself. And so these things that we know are real and can happen. And it's just important to recognize what may be contributing to your problem, if you're having a problem in this area, and talking about it with your healthcare provider. So when we look at what is the risk for low resilience, some of the neuropsychological features, the most common features, anxiety, depression, cognitive impairment, irritability, and anger are the most common risk for persons who would develop in MS, low resilience. Less common would be persons who have disinhibition, psychosis, meaning that they're having hallucinations or wild mood swings, persons who have apathy, and behavioral disturbances. Those are much less common in MS, not that they don't exist, but much less common. When we talk about building strategies for being resilient, I like to tell persons to stay hopeful. Again, as Dr. Issa marched through that timeline of where we've been, I started practicing in nursing in 1981. And when I was in nursing school, they didn't even teach us about MS. And as I went through graduate school and whatnot, we got a smattering of that. But I graduated from graduate school when the first disease-modifying therapy was coming out, as Dr. Issa graduated from med school. So our evolution in that short period of time, from having nothing to having what we have, I tell persons all the time, stay hopeful, because I am hopeful that one day we will have something that is good, a cure. We know that in the next year to 5 years, there's going to be several drug companies that are going to start looking at remyelination. So that's a lot is happening right now with rats. Looking at that. There's a lot about the immune system that we're still learning. So stay hopeful. Keep yourself active and keep yourself involved in your care, because you can't check out. If you come into our office and just are not engaged in your care, that is not a strategy for building resilience. You need to really stay engaged in your care, and you need to develop a partnership with your provider. And I tell persons that, in my mind, this is the most important thing. Dr. Issa said where he works, I work in the same place that he works. There are 4 neurologists in our practice, and there are 4 nurse practitioners. We see a lot of patients. And you know what? I work for the best group, I think, in town. But I have persons that come tell me, well, I see this person and they're just wonderful. And then I have somebody else that come tell me that I saw that person and they were just horrible. And you know what? I have heard persons say about me, well, she sounds good, but I didn't get that experience. So, there's got to be a bond between you and your provider. Sometimes that clicks from the first. Sometimes it's something that you have to nurture. But over time, you should develop that. And if you're not developing that, then what I tell persons, it is all about you. I mean, I hope that I meet every single one of my patients' needs. But if I don't, I'll be the first one to tell you, please, let me help you find somebody else who might be able to help you. Because if we're not clicking and if I'm not meeting your needs, then I don't want you to come see me. And I'm sure most providers feel that way. We're there because we want to help persons, but it is all about you. And so when you're thinking about that, the person that you see should be respecting you as an individual, should accept the fact that you want to make a choice and engage you in the choice, should consider your ethnic and cultural aspects, consider your healthcare beliefs and values, respect your confidentiality, and focus on your well-being. So if you're not finding that, again, Orlando is really a big area. I've been around the country, and there are some areas where there's only a neurologist, no nurse practitioners, one neurologist for the whole big area. And persons may drive 4 or 5 hours to be able to see another neurology team. We don't have that problem here in Orlando. So I would tell you again, if you can't find a partnership with that one, there are others to be had. So what are strategies for building resilience? Self-awareness, knowing about yourself. Self-regulation. Sometimes that means that, again, you prepare for things, you don't let everything just blurt out of your mouth sometimes. You're optimistic, you have mental agility, you think through a problem in a process. Dr. Issa gave you great tips on thinking conceptually of problems and trying to figure out what may be and have that type of discussion with your provider. So having some mental agility. Character strength. So we all have different things that we are stronger in than others. So build on the things that you're strong in and then develop things that maybe you're a little bit weaker. So if you're a very caring, compassionate individual, then you build on that part of helping someone and becoming stronger before you start building on maybe that you're not a person who is into facts and figures. Build on that first. And making a connection is extremely important in building resilience. So the biggest thing is focusing on what you can do. So when we're talking about wellness, it's really, well, what can I do on a day-to-day basis? I've got this disease. Maybe today it's not speaking to me, and you want it to not speak to you. So you don't want to forget it on the day that it's not speaking to you, but you should always be thinking about, well, what can I do? Believe it or not, those persons who don't have MS, a lot of persons think about, well, what can I do to make sure that I'm healthy today, tomorrow, and the next day? So thinking about specifically in MS with your medications, thinking about that these medications are for me, not to me. I'm doing something to help myself. This is to help me, not to me. Thinking of MS as really an opportunity. You know, there'll be crises along the way, but maybe this is a way for you to branch out and do something and share what you have with others. Typically, there's some silver lining in some part. You'll get some connection with someone else. Identify factors which are not predictable. So knowing that some things you can't have complete control of, but there might be other things that you can. In other words, when Stuart started the meeting tonight, he talked about things turning off the cell phones. He oriented to persons to where the bathrooms are. When you leave here tonight, you've been drinking caffeine. That tea is not decaffeinated. The water you've been consuming, maybe it's going to be later at night, so there's probably maybe not going to be as much traffic on I-4, but just thinking about, well, what if I did? Maybe I should stop in the bathroom. Dieting, looking at a good, healthy, well-balanced diet, exercise, sleeping, staying hydrated, using your support systems, and having a wonderful attitude. So those are things that you can do to build resilience. So examples of resilience, again, I touched on many of these things, being optimistic, feeling strong as a person, constantly self-talk, tell yourself, remind yourself of the things that you do well. Because you have MS, you have not fallen apart. There's a lot of good things about you, and remind yourself of those things. Handling uncomfortable feelings, so take care of those, have conversations, and maybe it's not comfortable for you to initiate a conversation about something. So maybe you need to write somebody a letter. Maybe you need to write that down and actually mail it. Think clearly and logically under pressure, seeking humor in situations, know where to turn for help, generally feeling control of your life, thinking about bouncing back after hardship or illness. close, dependable relationships. Over time, looking for challenges. When you start appreciating the fact, and I appreciate so much when I see some of the patients, I'm thinking, I don't know how you do it from day to day. I mean, I don't have any of those situations. And so oftentimes, I'm just amazed at how you guys do it from day to day. Well, that's sometimes what you need to think about. Think about how you have overcome. Think about how you have been successful, and be aware of your capability to handle such situations. Because, again, some of us would think, I don't know that I could deal with that. I mean, I have persons sometimes come into my office and tell me things, and I'm thinking to myself, you did what? And yeah, I just did, and I just got on. I'm like, wow. Having sense that things happen to you for a reason, or that things just haphazardly happen to you, and being more positive and moving through challenges. So now, in flipping to another channel, talking about wellness, we're going to talk about general health issues. And I always like to bring this up because, oftentimes persons do come into our offices, and I'll ask my patients, well, who's your primary care doctor? When was the last time you saw your primary care doctor? And even today, I had a person come in and presented with something that I don't treat this at all. And it's, so you need to keep a relationship with a primary care doctor, keep yourself healthy, work on those type of things. So routine health screenings that should occur for women. So breast cancer, self-evaluations, you should be doing this on a monthly, self-examinations, mammograms at least at the age of 40, and depending on your family history, mammograms may start earlier. You may also be able to have some of the BRCA testing done, some of the genetic testing done, depending upon family history. So that's extremely important. There is nothing about MS that will cause you to have an increased rate of breast cancer. Although cancers are reported in some of the monoclonal antibodies, there's not a specific indice for breast cancer. So, just again, be mindful of what is typical health. Cervical cancer is typically having pap smears from the age 21 to 65, at least every 3 years. And starting at the age 30, persons should have HPV screening at least every 5 years. Now, there's a vaccine for that. And so they're recommending that boys and girls start being vaccinated for HPV. It's the most common sexually transmitted disease. And they're recommending persons be vaccinated between the ages of 11 and 12 years old. So again, that's something to consider. And even persons that are in monogamous relationships, evidently that's extremely common. Colon cancer screening starts at age 50 to 75. Again, for typical individuals, your family history may dictate something different. Osteoporosis, we're going to talk about that a little bit more, but typically starts at 65 for healthy individuals. But for persons with MS, depending upon your steroid history, 40 or younger might be when you start being screened. Hepatitis C should be done at least once and then repeated if you have risk factors. The same with HIV testing. And lung cancer, 55 to 80, depending upon your history. And whether you're ever smoked and family history, things of that nature. So annual screenings. Everybody should have an annual visit with their primary care doctor. And what should be part of an annual screening? Well, the prevention and what is in the literature should be included in every health screening. Depression, diabetes, high blood pressure, high cholesterol, obesity, sexually transmitted diseases, and a review of your immunizations. So this is something that should go through every annual physical that you have. And so you may not even recognize that some of these things are occurring. But again, These are the big things that you should be screened for on an annual basis. And this is really hard. Don't worry, you're not having an MS moment. This is a snapshot, so it is not a good picture. I just wanted to point out that there are some vaccines that are here in red. You can go to the CDC and look at this if you want, but the red ones are live viruses. We typically don't like to give live vaccines to persons who have MS. There are certain situations that might be necessary, but typically we don't. And so this would be your primary care doctor would know the schedule for these, and it would tell your primary care doctor if persons have certain chronic illnesses that there should be some check. But always check with your neurology team when you're talking about a live vaccine. So I like to talk to persons about this thing called the happiness advantage. And really, happiness gives your brain the competitive edge. So it's a misconception that success breeds happiness. It does not. I mean, we can look through the paper any single day or People magazine any single day. Happiness is a choice. And so waiting for happy limits, to be happy for limits on your potential for success is really the opposite way. So there's no single meaning for happiness. It's relative to every single individual. And it's relative to based about how you feel about your own life. I mean, if I described, I had a day off yesterday. It was a very rare thing. But if I told you what I did yesterday, some of you may be thinking, oh my gosh. But yet you might tell me something that you did on your day off, and I might be thinking, ooh. So really, again, happiness is a choice. And so choose to be happy, and you're giving yourself, your brain, a competitive edge. So think about that. And again, that stems back to building resilience. So now we're going to talk about nutrition. We'll talk about what is nutrition, what is a healthy diet, common myths, and some research that's been done. So nutrition is nourishment. It's food required by organisms and cells to stay alive. The consumption and utilization of foods to maintain optimum health is really what nutrition is. So a healthy diet is much more than just counting calories. It's more about a variety, a proportionality, moderation, and I encourage persons to go to the government's My Pyramid website. That's one of the best, most simplistic websites that I have seen for helping persons with a diet. So it's much more about what and how you eat than counting calories, and so it's extremely important. So there's some common myths around MS and diet. Some people believe that their diet caused their MS and that a diet can cure MS, that multivitamins are good for me, and that supplements can't hurt me. So those things are all being challenged as of this moment in time. I mean, I had a patient give me this very nice book, and I promised her, and I did. I read it from cover to cover. And despite the fact that this neurologist had a lot of really good things to say about eating and your immune system, there's not a thing in that book that he's been able to substantiate cures any neurologic condition. Although he had some personal testimonies. Again, I think that eating healthy can do that for individuals. So your diet cannot necessarily cure your MS, but can it make your MS symptoms better? Yes, it can. I can tell you that a healthy diet will make your MS symptoms better. And so we'll talk a little bit about that. But outside of, we've looked at now in children, so adolescents, children who have obesity and high salt intake in adolescence, that does increase their risk slightly of getting MS. So we have discovered that now. That was something that came out in the last CMSC meeting. But that's just, again, one of those multiple variables that we put into this mix and say, okay, well, if you've got, so many of these, it's just going to take one more thing and you might come up with MS. So there's no direct link, but again, being healthy all along will prevent you from having any degenerative disease. When we look at vitamin D, we know that vitamin D is recognized as one of those environmental factors that contribute to potentially persons being diagnosed with MS. And really, we know that the vitamin D requirements are much higher than we previously thought. We know it's very hard to get vitamin D through your diet. We know that studies have proven that vitamin D will regulate T lymphocytes, and those are your regulatory T cells, the ones that kind of keep your immune system from being hyperactive. So we know that that works. So typically we want persons, this CMSC is saying that persons' vitamin D levels should be 70. I keep people between 60 and 100. A normal vitamin D level, depending upon the lab, is going to be as low as 30 and be considered high at 60 in some labs. So again, if you have a immune-mediated disease, most persons are recognizing that a higher vitamin D level is extremely helpful. The key is that vitamin D is a fat-soluble vitamin, and yes, many of us, and for the many years that I've been doing this now, was very worried about making persons toxic, and have yet to make someone toxic with vitamin D. And I have several of my patients that are taking 50,000 units every single day. Again, they're under close monitoring of blood levels, so I don't recommend, you have to get a prescription to do that. But if you're taking a vitamin D supplement, you should have regular vitamin D levels drawn, so it's extremely important. Looking at vitamin C, it's not recommended that you consume extra vitamin C because this will stimulate T cells and macrophages, which are cells that go in and start cleaning up debris. Some people think that this is protection against UTIs. There hasn't been a study to show that, but it's better to use cranberry juice, although urologists have told us in clinical studies that cranberry juice really, it's not there. We believe it is, but they say in clinical studies that cranberry juice will not protect you from having a UTI. That being said, I still use it, and I think it's pretty good, and you can get cranberry pills even. So, but it's better to use cranberry juice or cranberry pills than using vitamin C. And despite what persons may think, there has not been a study that shows that vitamin C will decrease the common cold and viruses. So if you are one of those persons, well, I start getting the sniffles, I'm going to start loading up with vitamin C, and this is only going to last me a week versus it would have lasted me 2 weeks if I did. There's no clinical evidence that that has been shown in studies either. So, but you're not going to find a study in MS that demonstrates that vitamin C is exceptionally harmful either. We're just talking about theory of the fact that what this vitamin does. Vitamin B12 is extremely important. We know that vitamin B12 deficiencies can cause white matter lesions, cause anemia, can cause fatigue, and can cause sensory problems. So one of the things when we're diagnosing persons with MS, prior to saying they have MS, we've ruled out the fact that they've got a vitamin B12 deficiency. So vitamin B12 supplementation has typically, there's rare hematological problems where a vitamin B12 supplement could be harmful, but exceptionally rare. But most of the time, vitamin B12 is not harmful. It's a water-soluble vitamin, so if you take too much, you just have a little extra color in your urine, no problem. When we look at the omega-3 polyunsaturated fats, We know that these do have mild immunosuppressive effects, and there have been some small studies that have shown some benefit, but not enough to reach clinical significance. So if you've ever been to a drug talk where we're giving you the commercial on a drug, they'll tell you that, well, this did this, but it didn't meet clinical significance. So that's where omega-3s are in. There is some evidence towards moving in a positive direction, but not clinically significant. So it should not be considered an alternative to a disease-modifying therapy. There are persons who have certain medical conditions that you really need to be mindful of. It can interact with anticoagulants and antiplatelet medications and oral hypoglycemic medications. So it's something that you should make sure that you're discussing with your primary care doctor as well as with your neurology team. The other thing is it can cause the risk of bleeding, and that might mean that you have to supplement with vitamin E, and we know that vitamin E has been proven to increase macrophages and T cells too, so that would be another potential harmful vitamin for you. CoQ10 most likely does have antioxidant effects and can help your immune system, but high doses that are needed to do that sometimes can cause liver toxicity. And again, many of the medications that we give with MS go through your liver, so that's something that you need to be having a discussion with your healthcare provider about. And you should really avoid long-term use of CoQ10 because, again, we're not really definitive that this has long-term effect on MS. Caffeine, a lot of people, I put this in nutrition, find caffeine to be helpful with fatigue and mental alertness. There's no data to substantiate that really you will have improved cognitive function on caffeine. So you have to balance that. If you're using caffeine to help you with mental alertness or fatigue, think about the fact you consume that caffeine, it's going to take 45 minutes for you to get the maximum effect of that. And if you're, let's say, preparing for a meeting that you're going to have at work, so I'm going to have a cup of coffee. I'm going to have it 45 minutes before I go into the meeting. Guess what? I go into that meeting. I'm sitting in that meeting 5 minutes later. I'm because it's got a diuretic effect. So it's going to make you feel like, whether you have to go or not, it's going to make you feel like you have to go to the bathroom. So you're going to be sitting in the meeting and you might be distracted just because you feel like, I got to go to the bathroom. So just be cautious of that. It's a urinary irritant and can provoke many of the bladder difficulties with MS. So again, when you're being seen by a urologist, when you're talking to us about bladder problems, don't be surprised if we ask you about your caffeine consumption. And it can increase your risk of osteoporosis. So that's something to consider. Alcohol is a sedative to the brain, and you have a risk of a mood disorder and anxieties, increased risk of suicide in persons with MS who drink excessively. It does impair cognitive function, not only while you're under the influence, but if you are a regular consumer of alcohol, then you are regularly killing brain cells. Organic brain syndrome that happens from alcohol abuse. Unfortunately, there's not a good barometer for when that happens in persons. There are some people that can drink for decades and never get organic brain syndrome, but there are other persons that may only drink for 5 years and get organic brain syndrome. It does increase your fall risk. If you've already got some balance problems and you consume alcohol, and can worsen your bladder dysfunction. So salt intake is one of the newest things that has come out. The FDA recommends persons who are healthy can consume up to 2,300 milligrams of sodium a day. Newer research in MS demonstrates that salt will make your symptoms worse. There has not been yet enough data for us to say that it will cause your disease to progress, but it will make all of your MS symptoms worse. So we are recommending that persons restrict their salt intake to no more than 1,500 milligrams a day. Again, consult with your primary care doctor and your cardiologist to make sure that they're on board with this. But I don't think that many persons would have that problem, but just make sure that you do. There's other medical conditions that sodium restrictions are extremely important: hypertension, cardiac disease, vascular disease, and kidney disease, and diabetes. So it's not just MS. So relationships, Dr. Issa touched on a lot of this, and so I just want to touch on whether or not to disclose. And this is something that is extremely individualistic, and depending upon where you work, who you're talking to, your friends, what your level of disability is really whether or not you're going to disclose this. If you do, you can't take it back. So just consider that. If you put it out there, you can't take it back. And always be mindful of why are you presenting this and how are you presenting it. And so what kind of response do you expect to get from individuals will help you with whether or not you're satisfied when you tell individuals. Parenting and family. We know that MS affects everyone close to you. Dr. Issa touched on pregnancy, so no need to go through that. Again, family responses can be unpredictable, and there's usually an adjustment period. But know if you had a poor family environment, the diagnosis of MS may make that much, much worse. There are some families that pulls them together, but many families it does not. And many families it makes communication more difficult and really strains the finances, even if it's not presenting a financial issue at the time when you get diagnosed. Over time, just the worry of that sometimes can really shatter persons. So be very careful, and it's important for you to develop close, supportive persons to help you through this. Coping, Stuart's hand showing me the signs up there. Know that roles in families can change, and you really, it's key to be communicating. Do you always need to be the individual who does all the laundry, who cooks all the dinners, who does all the grocery shopping, who does those conservative roles of a woman? Well, depending upon the relationship you're in now, that may not be what you do at all. I mean, I stop at the grocery store because it's more convenient for me to stop than my husband. But most things in our relationship, he does more than I do. I don't take care of much of anything around my house. So you just have to be blending and finding out what works for you. But the key is communicating. Recognize that children will respond to MS, and whether you tell them or not, they're going to figure out that something's wrong. So it's better to find a good way to tell them. The MS Society has helped with this, but know that children can react by being angry, fearful, embarrassed, guilt, sadness, resentment. They can have depression and hopelessness. So it's important that if they start having problems, that you get them into counseling. And here are some of the behavior risk. If you start noticing that children's have increased concern about their own bodies, difficulty maintaining close relationships, they are growing up too quickly, behaving badly in public. These are some things that you might start thinking about. Maybe your children need some psychological help. Maybe the family does. So children will commonly ask questions about MS, and so the best thing is everything else with children. Answer the question that they ask. Don't answer what you think they're asking. Clarify what they really want to know, and ask them, "Do you understand?" And then just give them the answer that they want, because they may be just wanting to know, "Am I going to die? Are you going to die? Am I going to get it? Why is there no?" They might be asking very simple questions, and you're going to go through, a long dissertation, and might leave them more confused than they were before. So now specifically MS symptom is related to being a woman. And the reason I put headaches as number one is because headaches is the number one reason for any person to come to a healthcare provider. It's much more common in females than in men. We know that this disease is more common in females than it is in men. So a third of persons who have headaches had that before MS. But persons that have MS are going to be 2 times more common to get headaches. And despite the fact that headache is not listed as a common symptom, it really is a common symptom of MS because it's a pretty common general symptom. So when we look at the causes of headaches, we start looking at things like lesion location, that brain stem lesions, cervical lesions can cause more headaches. Sedentary lifestyle, different medications can have side effects relating to headaches. There can be other coexisting problems like sleep disturbance, thyroid dysfunction, and depression that can contribute to headaches. When we look at this is the general population, you see the tension type headaches, 78% of the general population get tension headaches, 16% get migraines. So this is general population. So again, headaches are very common. When looking at headaches, when we look at headaches, we look at pain and disability. Headaches can range anywhere from being mild to extremely severe and can be minimally disabling or can cause persons to have to go to bed and stay in bed for hours to days. So I'm not going to bore you with headache classification. The keys to successful management of headaches is really, number one, prevention strategies, trying to preemptively treat a headache, acute headache treatment, and then moving through. So as we look at acute migraine medications, there's non-specific drugs that work like NSAIDs like Motrin or Aleve, combination analgesics like the Excedrins. Opioids can be used, neuroleptic medications, antiemetic medications, nausea medicines, and we can use steroids. Specific medications, ergotamines, DHE, and triptans for acute headaches. The key to treating a headache is treating it early. Oftentimes, persons will tell me, well, I wasn't sure, and so I didn't treat it, and then the headache gets away from them. So really treating it early, using the correct dose and formulation. The thing is that if you need to use a lot of a lot of abortive medications, then you're going to need to come in and see somebody about getting a prevention medication. Thinking through that. So here's the list of a ton of acute therapies for migraines. When we talk about preemptive treatment, if you know that certain triggers are going to trigger a headache, like certain persons have menses-related headaches, and so we can treat them all through their menses so they don't have a headache. Persons that get headaches during sexual orgasm, we can give indomethacin prior to that, and consider any other acute treatment if not effective. So preventative strategies, the most important are lifestyle modifications. So keeping a headache calendar, trying to figure out your triggers, doing neck exercises, aerobic exercises, maintaining regular sleep patterns, eating regular meals, avoiding triggers. That's why you do a calendar, so you can figure out your triggers. And you can actually get an app. There are several free apps for migraines, so get an app and you can put it on your phone. And avoid overusing analgesics because that will cause rebound headaches. I'm not going to go through the preventative medications, but they're there. So looking at premenopause in women, I want to put these up here just to remind you that we're women, and women, things happen to you, and it has nothing to do with MS. So painful menses happens to persons, abdominal pain, that happens to persons, and that may not be your MS. So again, make sure you're looking into that. Contraceptive issues, that everyone who doesn't want to get pregnant has contraceptive issues. So again, I see more drugs listed as contraceptives than I've ever, it's been a long time since I ever prescribed a contraceptive medicine. So I tell persons that's really something you need to get from your OB. But again, the risk and benefit of that, being adherent to that, and the real risk is getting pregnant while on a disease-modifying therapy medication. Again, we talked about the HPV. Dr. Issa discussed pregnancy. So menopause, I just want to cover that. This is where you start becoming free of your menses. And so menopause is considered after 12 months of no menses. And in between getting to there, you can have irregular bleeding. Hot flashes often occur during menopause. Think about that. Heat intolerance. You get a hot flash from your MS, from your menopause. All of your MS symptoms may get worse. And you know what? When the heat goes down, those MS symptoms may not go away immediately. So think about that. Try again to think about that. During menopause, you're going to have genital changes and stress incontinence that are very common for persons who don't have MS. The tissues thin when your estrogen levels drop and can cause sexual dysfunction. It's the primary cause for sexual dysfunction in women for any disease. So again, think about how old you are and where you are. Maybe it's not your MS. Maybe it's something else. Again, there's increased risk of UTIs during this period of time, so cranberry juice is good. Stress incontinence, Kegel exercises are extremely important to consider. Osteoporosis is something that is extremely important. This really begins as young women and men really thinking about a good diet, exercising, and staying fit. And there's the high impact, low impact, and muscle strengthening are extremely important in preventing osteoporosis. Diet should be calcium rich and vitamin D. If you're less than 50 years old, you should be consuming 1,000 milligrams of calcium a day. If you're greater than 50 years old, 1,200 milligrams of calcium a day. And believe it or not, dried prunes have found to be an exceptional help in increasing bone density. So there was a study looking at food, and dried prunes do increase bone density. So if you have a tendency for osteoporosis, everybody should be out buying dried prunes. All right. So obviously there's several treatments for this, and we don't prescribe treatments for osteoporosis, but there are several of them out there. And so there's two different really big classes. So, again, that's something that you should be talking with your primary care about and having the bone density test done. Any questions, comments? I can answer anything you want me to answer, I believe. So if you need clarification of anything that Dr. Issa said, if you have questions about disease-modifying drugs, I prescribe as many as Dr. Issa. We do a lot of research in our facility, so there's not much I can't answer, I don't think. I'm sure you'll stump me with something. Okay, so her question was, she has friends that have been diagnosed with cancer. Does MS increase your risk for developing cancer? So the basic question is no, MS does not increase your risk for developing cancer. That yes, when we alter the immune system though, many of the disease-modifying therapies have in their label that there may be a potential increase in cancer. Even in the interferons, we have seen melanomas. We have seen breast cancers with the interferons, but not enough to say that the interferons caused those things. We have seen with Gilenya, we have seen cancers. There's not, other than the melanoma, there's not been a specific cancer with Gilenya that we have been able to, but we have seen a variety of cancers. With Lemtrada, in the clinical study, there were persons who got cancers not higher than the general population. So that's why the candor there is may. When you alter someone's immune system, part of what your immune system does is survey your body for these foreign invaders, abnormal cells. And so when you alter your immune system, potentially you would increase the risk that your immune system can't do its normal surveillance. So the best thing that you can do is, again, follow with your primary care about routine surveillance and doing the exams that you need to do. Doing breast exams. I don't know how many people who I ask about doing self-breast exam, and they look at me like I've got 3 heads. I'm like, well, you know, have your significant other do it for you. But those kind of things will change your life. Yes. Well, right, she's young. And lymphomas can occur at any age. Lymphomas can occur in children and can occur in young adults and older adults. So, you know, it's really hard. We would like to think that if persons get one immune-mediated disease, that they're not going to get another. We know that's not true when it comes to thyroid disease. So although there's not an increased risk for cancer with MS, you still have the same risks as the general population. So as much as I would like to say, well, gosh, you got MS, you shouldn't really get anything else. The Lord gave you one thing, he's probably not going to give you something else. But by the same token, don't stick your head in the sand, okay, I got MS, so I'm not going to get anything else. Do your regular examinations. And so that's why, again, I encourage persons always to be thinking about the fact that not everything is MS, and not everything that you have isn't MS. So sometimes I have persons, and I'd like to say it depends upon how long they've had MS, but it's not always the case. But some persons, from the time they're diagnosed, everything after that becomes, what's my MS? And their primary care and other people will contribute to that. Oh, yeah, go see a neurologist. But a lot of times it's something else. MS is a rare disease. But if you get complacent thinking, well, it's my MS, I'm on a disease-modifying therapy, and you don't have these other things checked out, again, you may be doing yourself a disservice. So when I'm with patients and they start talking to me about these things, that's one of the first things that's running through my mind is, okay, what supports that this isn't MS? What makes me think that this might be MS? And so I'm always ruling out that it's something else, because it could be something else. And oftentimes, you know, because when we do MRIs and persons present with disability or relapses, we don't always see real objective evidence of that. So the poor person who was talking about having not had a relapse in a long period of time, we know that neurodegeneration is occurring in individuals even when we can't measure it. So it's really hard to say that if you haven't looked at everything else, well, it's your MS. So you need to really make sure that you are looking at everything else, and you still are a human that has much more probability of having just about everything other than MS. Yes? Yeah, so it is hard, and those stories are very uncommon, but they're not unheard of. So there are times where person's symptoms, they may, especially persons that are very in tune to their body, may be able to discern certain symptoms occurring, but it's before we can see actual enough evidence. And a spinal tap is not a definite. 95% of persons, spinal tap is accurate. In diagnosing MS, 5% of persons will have a negative spinal tap and still have MS. So, unfortunately, time sometimes is what we need to be able to make that diagnosis. And, I don't know of an individual who hasn't hung in there, and over time we haven't been able to either exclude that as a diagnosis or include that. Excellent question. So, In head-to-head studies, we don't have a head-to-head study proving Athgar to be superior to Solumedrol or vice versa. And Athgar is rather expensive, unfortunately. And hospitals only keep it on stock for infants who have infantile spasms. So typically, if I'm using Athgar, a person is not being exposed to the hospital. And so the reason I use Athgar over steroids is if a person has not in the past had a good response to steroids. So let's say they didn't have good IV access, or they had side effects from steroids, or they got the steroids and didn't have an improvement in their relapse symptoms, or they it cost some persons more to get steroids than it does get to get the Athgar, because some persons, their insurance requires they be admitted into a hospital. That's becoming less and less, but it used to be some people did, and they have to go to outpatient infusion centers, and sometimes the co-pays for that. So sometimes there is a cost benefit for Athgar, because it's an injection you can inject yourself. You can either give it to yourself IM or subcutaneous. So the first thing is, if you have had a side effect or not had a good response to steroids, then Athgar is definitely the drug of choice for me. If a person does not have good IV access, in other words, I've had patients who have told me that they have had a home health person come out and stick them 3 or 4 times, and had another person come out and stick them a few more times, and then they didn't get it that day, and they had to go a couple more days before they finally found a person that could put an IV in them. And so, I mean, that's extremely painful, not to mention it delayed their therapy. Now, there's a lot of evidence when we look at the mechanism of action of Athgar, that Athgar works on your whole immune system, not just the MRC2s, which are the melanocortin receptors 2. We have 1 through 5. Steroids, man-made steroids, will only work on MCR2 pathway, whereas Athgar will work on 1 through 5. So it gives you a much more complete suppression of your immune system. And we believe that that makes a difference, and that's why some people respond to Athgar that don't respond to steroids. The other thing is, because your body is making its own steroid, you're getting a hormone, it's causing your pituitary gland, your body makes its own steroid. Most of the time, the side effects are much more dampened, if any at all. The risk of osteoporosis after Athgar use is much lower than after steroids. So if persons have osteoporosis, although it's in the package insert that it can contribute to osteoporosis, studies have shown it's less. The FDA wouldn't let them take that out of the label. So I would use Athgar in a situation like that. That answer your question good?
You did.
Thank you. So she was asking about your desire or your libido, that sometimes with MS that you lose that. And when you go on disease-modifying therapy, will that improve? Well, if the primary problem is coming from your limbic system in your central nervous system, that is the driver of your sexual desire, and your immune system is improved by drugs, and then your central nervous system can improve itself, then yes, just like every other symptom, there's the potential that it could get better. But for some women, it does not. And there is a pill for men called Viagra, and that helps men with their erectile dysfunction. There is nothing that will help a woman with her vaginal function other than lubricants and whatnot. But there is now a pill that will help women who have a hyposexual desire disorder. So HSDD. It's a drug called Addy. That's the trade name for it. Flibabersten is the generic name. Not every healthcare provider is going to prescribe this. You have to go through a REMS program. You have to certify to be able to prescribe it. I am certified to prescribe it, and I have prescribed it in a few women. It's not a drug that can be combined with alcohol. So if you are a person who cannot live without your alcohol, you can't have the pink pill. So let me just tell you that right up front. You can't have the pink pill. Because of the risk of hypotension, the risk of a drop of your blood pressure. So if you consume alcohol with Addy, the risk of of dropping your blood pressure dramatically is increased, and so therefore you could go unconscious. So that would not be good. But I have had good effect with women who are taking that. And so oftentimes it's not the parts. If the parts are a problem, they're a little bit easier to fix. Parts are easier to fix, but the brain is a little bit harder. So this drug actually goes in and stimulates the brain, chemicals in the brain, to actually make you feel more like, I would like to do this. And again, even if you say, I don't need sex, it's okay, your mate may not be saying the same thing. And so, again, for a healthy relationship, you need to consider that. You don't want to have your mate be doing nothing but being a caregiver to you. You don't want them to see you as a person with MS. You want them to see the person that they fell in love with. You want them to see you as a person. You don't want them to see you as MS. So you always want to make sure that you're maintaining that relationship that is separate from caregiving. Again, if that is a problem, there is a medication for that if your disease-modifying medication does not cure that over time. Good question. Yes. So her question is, with Tysabri, does it reduce the pliability of your veins? Does it make it harder and harder to get an IV? It's a once-a-month drug, and typically there's not a problem with IV access with Tysabri. It is a rare individual that is going to have IV access problems. So I would say the answer to that question is no. Are there particular individuals that may have difficulty? I have 2 persons who have ports put in, but both of those individuals, it was at their own insistence, and I fought them tooth and nail because it increases their risk of infection and other issues. So did not think that was necessary. The level of disease and disability. Excellent question. So the oligoclonal bands, OCBs, are what we are testing in your cerebral spinal fluid to determine whether or not you have MS. So it's looking at the oligoclonal is the part of the nerve, oligodendrites, that make that myelin. So when that myelin gets broken down, those cells are then in your cerebral spinal fluid. They shouldn't be there. And we compare what's in your serum, your blood, to what's in your cerebral spinal fluid, because you do have some of those cells in your serum. The higher the number has been correlated with a more aggressive disease. That being said, again, everyone is unique. I have seen some persons that have had oligoclonal bands in the neighborhood of 15 and have been very stable. I didn't have a problem with them. And I have seen some persons that initially came back with OCBs of 4, which is just nearly positive, and they go to heck in a handbasket. So it's something to put in the thought process of thinking, but in my mind, I believe in this thing called no evidence of disease activity. So I believe in the fact that we don't put a person on a drug and just go check them a long time after that. That we are regularly monitoring that report card. And at any point when the report card changes, when you're having relapses, you're having more disability, you're having more MRI activity, or you're not able to tolerate your drug, then we need to respond to that. So I try to tell persons to think of this as like you would think of cancer. You know, if you have more cancer come back, you're not going to say, it's only a little bit. I'll wait and think about that. No, you're going to attack it every time you have something happen because you don't want to get worse. And so that's the same thing with MS. Good question. Yes, ma'am. Excellent. So what she is saying is that she has been on 4 drugs, and in the past she has had changes on her MRIs, and now she's finding less changes, or her MRI's been stable, and she's having disability. So the report card really is relapses, MRI activity, disability, and I include the ability to take a drug, so adherence. So if you're becoming more disabled, that is a measure of your report card. We know that the MRI, even the best MRIs, don't show us everything. So unless we can prove that you have a progressive form of MS like primary progressive, if your disability is changing and that's not from anything else, in other words, we're managing your fatigue, you don't have any other medications that are causing you to have weakness, whatever your disability change, then you deserve a different drug. Excellent. So her question is that she is a woman of color and that her GI doctor is concerned about vitamin D going through her kidneys and her potentially having, because persons of color also tend to have higher risk of kidney disease because of high blood pressure. And so she is being told not to supplement with so much vitamin D because of that potential risk of kidney disease. Well, in order for your level to go high, that means that you have to keep the vitamin D in your body. So it's broken down in your liver, and if it's broken down in your liver, then it will be excreted after going through your kidneys. If your liver has broken it down, it's not going to cause damage to your kidneys. The only problem you're going to have is if your level of vitamin D goes high, then you can also have calcium problems and other electrolyte problems. So as long as your neurology team is managing your level, the other issues should not be a problem. So if you're taking a large amount and your level is not being monitored, then yes, I think that's a concern. The other thing I have found with vitamin D supplementation is telling persons to take their vitamin D with food, especially a fatty food. That, for some reason, helps the absorption of the vitamin D. So make sure that you're not taking your vitamin D on an empty stomach. Okay, so her question is, she gets frequent urinary tract infections because she has urine that stays in her bladder because she can't empty her bladder. So, and that's because of her MS. So her urologist has her on a antibiotic prophylactically. So she's taking a low dose of an antibiotic to prevent a urinary tract infection. The long-term use of antibiotics will increase your resistance, so that antibiotic will be less effective over time. So long-term use creates resistance and creates organisms that learn to recognize that antibiotic. So even if you take that antibiotic at a higher level, it may not be able to kill that organism. So that's the risk there. When you frequent urinary tract infections from MS are usually a problem with persons who are having bladder spasticity, that they can't empty their bladder or they can't store, and so they're having incontinence and having problems with hygiene. Very infrequently is it a hygiene issue. More the time it's that you have old urine in your bladder that is then just a breeding ground for organisms. So the key to not having a urinary tract infection is to actually empty the bladder. So you and your urologist need to work at what is it that you can do to get that bladder empty. Do you need Botox? Do you need intermittent catheterizations? What is it that you can do to empty that bladder? The other thing is that when persons are on long-term antibiotics for UTIs, you can colonize, not only do you make your body less susceptible to that organism being responsive to that antibiotic, but you also make your bladder specifically find that that organism then, so to speak, likes that antibiotic. And so it actually gives you what we call a colonized urine, that you will never clear, that you're not always having the symptoms of a UTI, but you're always going to have that bacteria, and we will never get rid of that. So most urologists that I talk to are strongly against long-term antibiotic therapy. And even in persons who have colonized, they will not treat them unless it's a different organism that they see. And again, persons who have colonized urinary tract problems typically don't have the symptoms that go along. Their body becomes used to it, so you don't get an increase in your immune system. So because your immune system isn't going to increase to try to fight off that because it's used to living there. So the biggest risk of an infection and MS is a relapse because your immune system gets hyperactive trying to go, so you're not going to have that problem. So again, the symptoms of a UTI are what we worry about, and the symptoms that will then cause your MS symptoms to be worse and then potentially trigger a relapse. Good question. Second opinions are good. Yes? Well, again, so she was talking about being on a different antibiotic, a very low dose, and cutting that antibiotic down, but using it on a daily basis to prevent urinary tract infections. And so it's very good that your neurologist is helping so that you don't have to see that urologist very often. But again, being clear that the root cause is being treated and that you're not masking that. So again, I don't know what the root cause is, but being clear that the root cause is being treated. If it's bladder spasticity, that you are taking something, getting treatment for that so that your bladder can relax so that you can empty your bladder. So again, those are good questions that are answered by urodynamics. Urodynamics can help whether or not, and they can do urodynamics after they give you Botox. So you can determine whether or not Botox has been effective. Yes, any medication that dries out your mouth will dry up all of your other areas where you have moisture. So it will dry up your tear ducts, will dry up your GI system so you can have constipation. It can increase your urinary retention because it'll make it harder for you to urinate. So all of those things. So if dry eyes is a problem, that you can try lubricant. But again, always monitoring the risk-benefit of the medications and being clear that the benefit you're getting is worth the risk that you're taking. Yes. No, but there's risk to having dry eyes. There's risk to having constipation. There's risk to having a dry mouth, that you can have increased cavities, so the risk of the medication that's causing you that side effect, and then the benefit that you're getting from that medication, and trying to balance that out. Dry below, there's all kinds of wonderful creams. There's estrogen creams. You can use suppositories for that. You can actually, there's medications that can be prescribed that can increase your vaginal secretions. And so, that's a good question. All right, they're letting the men in. You guys have been a great audience. Thank you so, so much.
We all have to thank Patricia for being here today. And also, we need to thank Teva Neuroscience for having us, or giving us the funding to do today's program. So we want to thank Teva for doing this. And again, we have to know that, we can't do our programs without the support of the pharmaceutical industry. So we do thank them. There's a self-help group leader in the room. There was actually more than one, but one didn't want to speak. And so we're going to have the other one just say something for 2 minutes. And then maybe the next time we do a program, the other person will also speak. Thank you.
My name is Yvette Soto. I'm with MS in Motion. I was diagnosed in 2005. Right now we're on a little break, but we will be starting up in about a month or two. But we will be doing meetups in Orlando in a more social environment, because that's something that several people had said that they were interested in, as opposed to sitting down and just discussing some of the same things. So that's something we look forward to. And we're also considering doing other more social activities like water Zumba, things like that. So if you're interested, I have a Facebook page called MS in Motion. Feel free to attend that. My Twitter is also at Stilettos for MS. I do my MS walks in stilettos, the entire thing. And so you can follow me on Twitter as well. Thank you.
Okay, great. So just so you all know, we do forget, we do have busy lives, and we just want to remind you all the time about the programs to attend. So that's why we do that, and we got you here, so it worked. Okay? Thank you.